Hello, once again. This time let's talk about hyperamesis gravidulum, which is one of the conditions which may occur in pregnant women and may be of concern to the health worker. So by definition, hyperamesis gravidulum is excessive vomiting during pregnancy, which occurs in the first trimester, and it can continue onwards. This condition differs from morning sickness because in this, vomiting persists throughout the day and sometimes at night, so that the patient condition becomes impaired. So by brief definition, there is what we call morning sickness, whereby mothers vomit when they are having early pregnancies. They vomit, they get what we call the tylism, to spit out, and usually as the pregnancy grows, these mothers become stable. But when we say that hyperamesis gravidulum, it occurs in the same time like the morning sickness, that is the first trimester, but this vomiting may continue onwards and it persists, and these mothers may vomit throughout the day, sometimes even in the night, and as they vomit, they usually become so weak that they may fail to do everything. The only difference with morning sickness, like it is said, morning, as the day goes on, these mothers may not continue vomiting. If there is nothing that precipitates vomiting, like food smell, this mother may not vomit and may wait till the morning, the following day, maybe when she starts to brush, that is when she can vomit. And this mother can omit things like Vaseline, toothpaste, and the vomiting may not persist. But for mothers with hyperamesis gravidulum, there is no remedy, local remedy, that can stop the vomiting. This patient or mother will vomit throughout the day, even in the night, even without a cause, they will continue vomiting. And as they vomit, they will lose a lot of water, so they will become dehydrated, and their conditions, they become weak, and they cannot do anything on their own. So as they vomit, again, as I said, they lose weight, and they also become dehydration and weak. Okay, what are the causes of hyperamesis gravidulum? Elevated levels of hCG and an increase in maternal levels of estrogen during pregnancy. When the levels of hCG, human choreogonadotrophic hormone, increases, when you look at mothers with multiple pregnancies, some mothers with abnormal pregnancies like molar pregnancy, they have very high levels of hCG, and this can be a cause of hyperamesis gravidulum. Family history of hyperamesis gravidulum leads to a threefold increased chance of the condition occurring among offspring. So this can be inherited. I have no explanation. Emotional changes due to pregnancy hormones such as progesterone, psychological factors related to previous pregnancies. It is also very common in prime gravidas because they are experiencing hormones for the very first time. Multiple pregnancies, hydatidiform mole, and polyhydramnios because of the large uterus and the big placenta producing higher level of hormones. So all these can be a cause of hyperamesis gravidulum. So signs and symptoms, of course, we start with the subjective data. The mother will report persistent nausea and vomiting, severe vomiting, unremitting nausea and vomiting, meaning the mother will report vomiting every time. Unremitting, there is nothing which stops it, so the mother will continue to vomit. The vomit initially contains undigested food, bile, and mucus, and later it can contain blood and materials that resemble coffee grounds. So the problem with Hyperamesis gravidulum, these mothers vomit even before they digest the food. That is why they become so weak. The moment they put everything in the stomach, anything in the stomach, they will push it back. So when you look at the weight, this mother will lose weight of 5% or more of a pre-pregnancy body. For example, this mother was 50 kilograms before she became pregnant, and now she's pregnant. We expect her to gain weight, but instead she is losing weight. On examination, we are going to find out signs of dehydration like sunken eyes, dry mouth, coated tongue, cracked lips, etc. All these signs and symptoms, they tell us that the mother is severely dehydrated. And why is she dehydrated? She's not digesting anything in the GIT. So breath smells of acetone, which is a sign of ketosis, and signs of muscle wasting. So when this mother breathes, the smells will smell acetone, and these are signs of severe sort of malnutrition. The mother will report constipation because she will not be passing out anything because she's not digesting anything. Jaundice because of the effect on the liver. Physical and emotional stress, difficulty with activities of daily living, and this mother can come in confusion, delirium, headache, lethargy, etc. So on investigation, this mother will have scanty urine due to dehydration, and this urine will be concentrated with a very high specific gravity, and it will contain acetone. These are all signs of severe dehydration. So on management, this condition is not managed in the maternity center. So when you get it, yes, don't just push the mother to the hospital without doing anything. Do what we call first aid and then refer the mother to the health facility. And in the maternity center, we think that you put up an IV line and put up a fluid before you can refer this mother to the hospital. Admit this mother in a warm bed with in a well-ventilated room. Remember, this mother is lethargic, so she needs more rest. Reassure the mother and the relatives and ensure enough rest, making sure that there are no disturbances. Some of our pregnant women, they come with the whole of the family, they want to check on her. So teach them what to do and tell them to let the mother rest. Take those history of stressors, find out when the condition started, how is the vomiting throughout the day, how is the vomiting in the night, how is the frequency, what is containing in the vomiters. So here we are ascertaining whether it is morning sickness or Hyperamesis gravidulum. So we shall request under investigations for urinalysis to check out any urinary tract infection. We can use a dipstick urine test, and it will quantify ketonuria. malaria slide to rule out whether the cause of vomiting is malaria. We must rule it out. We should also confirm pregnancy. Why? Because we said high levels of HCG. These mothers may be having HCG due to a hydatidiform mole or a molar pregnancy. And before we can continue managing, we must know that we are really dealing with pregnancy, not any other condition. Because this mother is vomiting everything, it means her body is going to be deprived of food essentials, especially iron. Therefore, this mother may look anemic, of which we must also manage anemia. Full blood count to rule out any infection like anemia, hematocrit, and blood glucose monitoring to find out what is the hematocrit levels, what is her blood sugar. Ultrasound scan to confirm whether the pregnancy she has is viable, and also exclude either any multiple pregnancy and trophoblastic disease. So when we confirm that is his hyperamesis, we admit the patient. Because this patient is vomiting, we may allow her, or we may stop her take anything per mouth. That is what we say, that we keep patient nil per mouth. Some books say nil per os. It means we are saying that this woman should not take in anything through the mouth, because whatever she puts in, she's continuing to vomit it out. So because there was already an established IV line, rehydration along with placement of electrolyte is very important in the treatment of hyperamesis. Remember, as this woman is vomiting, she's losing a lot of electrolytes. So we are supposed to replace electrolytes. So under the rehydration fluids, we can use normal saline, or we can use Hartmann solution. These are suitable solutions, and they have potassium chloride can be added, and they help in the replacement of electrolytes. Then potassium chloride is added to aid in peristalsis, and calcium gluconate 20 ml of 10% to treat the electrolyte imbalance. So when you have these drugs, we shall put them into the into the normal saline or the Hartmann's solution. These mothers are prone to vitamin B12 deficiency, so we can give them vitamin B12 to improve on the absorption in the intestine and aid digestion of carbohydrates, protect the liver, and to maintain the health of all the nerves. So we can give them vitamin B12. So antiemetic drugs such as promethazine or Finnegan 25 milligrams may be given. Under antiemetic drugs, metoclopramide 10 milligrams every 8 hours for 24 hours. Chlorpromazine, which is Lagactil, can also be used. Supportive drugs like folic acid and ferrous sulfate to correct anemia, because this woman was starving, so she may be anemic. Remember, the GIT was empty for some good time, so we may need suppositories to correct on the constipation. Then we shall give thromboembolic stockings, or low molecular weight heparin may be used as measures to prevent the formation of blood clot. Remember, blood clots are very common in cases of dehydration, and this mother is presenting with severe signs of dehydration. So when the patient's condition improves and vomiting stops, she is allowed to take on the oral fluids. Remember, in the beginning we said we keep her nil per os, and we advise on a light diet, which can gradually continue to change if it is steroidated, if the mother is not vomiting it. So these are the key nursing care, which may not be specific, but they are very relevant in the management. Reassure this mother, because mothers, they may not know what is happening. Keep the patient in the corner of the ward, away from smells of cooking. If you don't have an isolation room, remember in the ward, the neighbors are bringing in food, are bringing in things for the other mothers. So you rather keep this mother slightly away from all these triggers which may cause vomiting. Careful attention on hygiene with daily bath and frequent mouth care, especially after vomiting. So if the patient is not so ill, we can advise on that. If the patient is so ill, we can work on them. I know midwives, you forgot all these procedures of mouth care, bed bath, but of which we are supposed to do. A vomitous bowel will be emptied quickly because of its sight and smell. Sight and smell, it may cause more vomiting. In serious conditions, observation should be done for hourly, including checking for signs of dehydration. The weight should be taken at least twice every week to see the progress of this mother. Remember, this mother is not passing enough urine, so we can go ahead to monitor bladder output in relation to what we have put on. So we continually carry our record on a fluid balance chart, fluid input and fluid output. So as we are nursing this mother, there are serious signs we must watch out, which may indicate that this mother is in danger. One is the rise of pulse over 100 beats per minute. This indicates that the heart is becoming weak. So as we nurse this mother, taking the pulse rate should be very frequent. Rise of temperature above 38 degrees and over is a sign of infection, which should also be taken note of. Jaundice or bile in urine is always a sign of liver damage. So anything like deep yellow coloring of urine or greenish coloring of urine is a sign of liver damage. Persistent albumin in urine, so what does it mean? That urine testing should also be done frequently. And if this mother drops the blood pressure, that is also very dangerous. The mother may present with double vision, which may be associated with nystagmus. That is an involuntary and rapid movement of the eyeballs. This is also a very serious sign of damage, loss of memory, delirium, drowsiness, etc. So as we manage this mother, we should watch over all these serious signs. And if nothing is there, the vomiting has stopped, has decreased, the mother can tolerate oral feeding, then we can discharge the mother through antenatal, such that she comes back for antenatal visit. And as we discharge here, we shall talk of the diet, of course, which she can tolerate. We shall say balanced diet, but only what she can tolerate. Prevention of further vomiting, that is, we avoid the triggers like fried food, cooking oil, maybe those spices which are put in food. We tell her to avoid them such that the vomiting is not triggered. To avoid worries, report any more vomiting, come back for antenatal clinic, and we may advise her to change the environment if it is the trigger. You never know, it is the husband triggering her vomiting. We tell her to go to her mother. and then be nursed. If she settles, she will come back. So hyperemesis gravidulum can come up with complications to the mother like dehydration, ketosis, renal failure, malnutrition, anemia, brain and liver damage, cardiac weakness, deep vein thrombosis. All these can be complications which arise with hyperemesis gravidulum. Then our baby can be aborted. This baby can be delivered as a premature baby. The baby can lack enough nutrients and get retarded intrauterine, and if not handled well, the baby may die intrauterine. That is how serious hyperemesis gravidulum. Now in labor, this mother may have prolonged labor, fetal and maternal distress, may bleed in between delivery. And on puerperium, she will have poor lactation and subinvolution of the uterus. Why? Because the body is dehydrated, so this mother may lack breast milk. Postpartum hemorrhage, here we may say that any slight bleeding which may change the condition of the mother, even if the mother is not bleeding physically, but any slight change. Remember, this mother, at one time we suspected her being anemic. So any slight bleeding can lead to postpartum hemorrhage, and this mother can automatically become mentally disturbed and they get puerperal psychosis. With those few remarks, I beg to say good afternoon.